Hello, my name is Mehdi Hamadani at Medical College of Wisconsin in Milwaukee, USA. Today I will be talking about our recent discussion about cell therapies for relapse refractory mantle cell lymphoma at the educational session during the virtual EBMT meetings. So broadly speaking, in patients with relapse refractory mantle cell lymphoma, we have three cell therapy based options. Two options are traditional options like autologous transplant and allogeneic transplantation. And in more recent years, cell therapies are coming into that space very rapidly. So when we specifically think about a relapse refractory mantle cell lymphoma, typically, not always, but typically most of these patients might have undergone an autologous transplant in the frontline setting, and that option is generally not relevant. But in regions where access to cell therapies is limited, or where good and strong allogenic transplant programs are not present, it is still a relevant option for patients who didn't undergo autologous transplant in the frontline setting. So for in the subset of patients who still have chemo responding disease in second or third line, I think this option still needs to be considered. But for the vast majority of patients who have undergone this option in the frontline setting, once patients relapse, we have to make a decision about whether those patients need cell-based therapies or they can achieve good disease control without cell-based therapies. So I personally look at certain high-risk features in those patients. If somebody has undergone an autologous transplant in the frontline setting, I see how quickly they relapse after an autologous transplant, and some unpublished registry data suggests that if patients relapse within the first 18 months or so, their outcomes are poor. So if they relapse early, that's a bad thing. Or if they have clinical high risk features like very high MIPI or MIPI-C score, if their Ki-67 is high, if they have genetic high risk features like TP53 mutation, or they have complex cytogenetics or biallelic deletion of chromosome 17p, then these are patients where you should think about cell therapies early. uh, in patients who do not have these high risk features, I think they can have good disease control with novel agents like BTK inhibitors, lenalidomides, and other agents in development. Now once you decide that a patient is high risk enough, then the main choice is between allogenic transplant and cell therapies. Allotransplants have obviously been used for a very long time. Limited prospective and a number of retrospective, including large registry studies, show that it's a curative procedure. It's not a commonly used modality in non-Hodgkin lymphomas. It is still dogged by problems around non-relapse mortality rates and graft versus host disease rates. So with the availability of cell therapies, my cautious opinion is that if cell therapy is available, just because of the safety signature, I think that's a reasonable thing to consider first. Obviously, the timing of cell therapy is controversial. The label in USA for cell therapies is very lax. You can essentially perform cell therapy in any relapsing patients without regard to their prior therapies. The label in Europe is more restrictive. For mantle cell lymphoma patients, you need to fail two prior therapies, including a BTK inhibitor, and the soon to be published combined ASTCT, CIBMTR, and EBMT guidelines actually endorse that option. So in high risk relapsing patients who have seen a BTK inhibitor, I think if cell therapy is available, either commercially or on clinical trials, that is a reasonable way to go. And the data, at least from Zuma 2 study, show that this therapy produces very high response rates, and the progression-free survivals at 1 year are around 60%. I do think allotransplant will continue to play some role in the management of these patients as a time-proven cell therapy options, particularly in regions where cell therapies are not available or in patients who fail cell therapy but are able to achieve disease control with subsequent novel agents, and in patients who are not good candidates for cell therapies, including patients who are developing marrow disorders, deep cytopenias, evidence of clonal myeloid disorders in the marrow. So, in summary, I think it's an exciting time for patients with mantle cell lymphoma, with increasing number of cell-based therapy options, as well as novel agents for the management of these patients. So, thank you, everyone, and I appreciate your attention.